words and tell you what you get. Hopefully in a few years, if the studies pan out. Last set of tricks. So how close are we to putting this stuff in a clinician's hands? Here's the game we play. I've got a group of clinicians. They come and sit around the table once a month, and we do a case conference. And we want to talk to them about brains. Our criteria must be understandable by clinicians, must speak the language of therapy. And as Dr. Greenfield has taught us, it must not be pseudoscience when we do this. Why do this? Why put these brain scans in the hands of clinicians? One thing is patients want it. A review by Illis et al. That I'll recommend to all of you from last year says that patients overwhelmingly tell us, if I just had a brain scan, I'd feel a lot better. I'd feel less stigmatized for my depression. Turns out their providers think so too. But what's worse, patients tell us, if I just had a brain scan, I would comply with treatment. I would take my medications. I would do my homework in therapy. I would come to my therapy appointments more often. I'd show up to my doctors more often. Down the line, anything you want, if I just had a brain scan telling me this is what I should do, it'd all be better. So there's some demand for this work. Let's see if we can make science, right? So 1 week prior to a roundtable, our coordinator selects a patient, a completed patient from one of our studies. And the clinician prepares a case report. Not talking to the clinician, one of our researchers sees just the brain data, and they prepare a case report. And then we have the grand reveal where we share and compare the case reports and see how well they match, and ask for feedback on what would help next. So we came in. The first month we tried doing this, I came in and I said, the thing I know about is amygdala activity. So I looked at that in the patient. How did they respond to negative words? Gosh, look, here was my patient before treatment. Here are the controls. Here's my patient before treatment. Here's my patient after treatment. And I said, therapy must have been a resounding success because their amygdala activity went down. That was the extent of what I told the clinician. And the clinician said, yeah, that's great. But you were talking about negative words. We didn't talk about negative things. In the therapy, it was really this patient couldn't embrace anything positive. And the problem was they turned the positive things negative. You'd have to show me something about how their brain reacted to positive things for me to even care. Luckily, I happened to have my computer on hand and could pull that up immediately. I hadn't looked, and I was just praying. And it turns out that before therapy, the patient had very low amygdala reactivity to the positive words. And after therapy, that went up. And we all jumped for joy and said that was terrific. Then one of our astute clinicians said, yeah, but you see this axis here? This is the dirty secret, folks. When you see neuroimaging data, this axis here is always percent change. It's something the MR people made up, the magnetic resonance people made up. And it's how many arbitrary units does it change compared to how many arbitrary units it started it with. What the heck does that mean? Clinicians don't know. They couldn't interpret it. They said, what I want is to be able to interpret this with respect to my other patients. At least give me some error bars, and ideally plot it with something I know. So we said, OK, let's take that sustained activity in amygdala, that's what I care about, and just plot that out. And I'm going to do something that all clinicians know about. Let's standardize the score. So let's take your activity and divide out by the mean of controls, or subtract out the mean of controls, divide by the mean of controls, and get what we call a z-score. A z-score is how many standard deviations different from controls is this patient. And all of a sudden, what we see is this pattern here emerge, where here are my patients. Many of my patients, the ones in red went down, the ones in blue went up. This is sustained amygdala activity. And what you can see is that a bunch of my patients start very high in amygdala activity compared to controls. This is one standard deviation above the mean and one below the mean. No, very few of my patients actually start anywhere near the controls. But then I have this other group that's below the mean of controls that I never saw before. Kind of interesting. This patient started well above the mean of controls, and it normalized. Now the clinicians could jump up and down too and say, yes, it normalized. I understand that. But we were left with a problem. These people here aren't in my model. They have low amygdala activity. Is that depression? Who are they? So I started asking clinicians about these patients. Who are they? Are they shutting down? And my clinicians told me something just about many of these patients down here. Well, turns out that they all had high levels of abuse, childhood abuse. These were the patients who they said in therapy shut down and looked a lot like their PTSD patients. They would dissociate, or they would remove themselves from the room, basically, when you talked about negative things. In the therapy, these therapists were excellent at helping them re-engage. And you see that everybody who's low went up, whereas everyone who's high went down. Different kind of patients. So this is one of them who, before treatment, showed an emotional word, and their amygdala shut off. After therapy, it actually turned on. And they were interpreting this as success. So now we're in a very interesting state. The clinicians have told us about a phenomenon we never expected, and what do we do with it? Well, we first looked. I wanted to tell you that the high amygdala people are our ruminators, and the low are maybe our anhedonics. That wasn't true. But our abused patients, maybe they were our avoiders. Chris Larson, who was here and actually did her Ph.D. in Wisconsin a few years ago, showed that if you take people who are phobic of spiders and you show them a spider picture, their amygdala activates. Healthy people, their amygdala activates and kind of stays on. The phobics, it goes on and then shuts right off more than the healthy people. And if you look at the neural activity that generated it, it's probably something like this. They have a short, sharp reaction and then shut off. Maybe they're avoiding, just like our spider phobics. Then I talked to Matt Knock about it. He studies self-harm. And he tells me that 65% of his people who harm themselves, like they cut themselves, are doing it because it helps regulate their emotion. But there's another 25% who are trying to feel something, feel anything. They're numb to the world, and they cut themselves to feel that. Maybe they're just numb. And then there's the possibility that they dissociate. They just sort of leave the room. A lot of our abused patients do that. And we looked. Now, after we heard this, we started giving our dissociation measures, so I only had 5 people to show you. Oh, I had some patients with borderline personality disorder and who varied in that. And we looked at whether they avoided. Pupil dilation in those patients shut off when they saw the emotional word. So the more you had a history of abuse, the more your pupil dilation shut off. These are correlations. And then when I say I put the word down here and numbers up here, they were looking up at the numbers. When I look at their eye tracking, they could look either down at the word or up at the numbers. They were looking anywhere but the word if they had a history of abuse. So maybe they were avoiding. But this dissociation thing, we gave a dissociation scale to our last 5 patients, and sure enough, the people who scored highest in dissociation had low amygdala activity,